work regularly with the breast cancer team at Coventry. Usually the day starts fairly early, where I meet up with the surgeons that I work with early in the morning, go and see most of my patients. We usually stagger them throughout the day so that the patients don't have to sit all day waiting and worrying about their operation all day. So we start off by chatting to them about their medical history. I'm interested often in the rest of them, not just in the procedure that they're having done. So we'll talk about their any medical problems they might have, any allergies, things like that, talk about medication that they're on. And then I'll talk about the anaesthetic side of things in conjunction with the surgeon talking about their work. So explaining what we do in simple terms, what they'll expect to see and find when they come to the anaesthetic room, and the staff that will be there. We have a chat about that, and then we talk about any potential complications depending on conditions that they might have. Once we've done that, I then obviously give them the opportunity to ask questions, anything they might be nervous about, and try and reassure them as much as possible about the day. Once I've seen all the patients, we then meet up in the operating theatres and we get together and have a team brief. So we talk about all the patients in turn, we talk about my side of things, any concerns that I may have about the patients, the surgeons do the same, and we talk about general things like, do we have all the right equipment, is everything working, to ensure that we have a nice safe day together working and looking after our patients that come in. Once we've done that, our patients come down to the operating theatre area and they come into the anaesthetic room. I have two nurses that I work with regularly who greet the patients when they come in and check all their details, and then we get them ready for the anaesthetic. So we'll put monitoring on, we'll put a cannula into the back of their hand so that they can have some anaesthetic medicine, and we might give them some oxygen before they go off to sleep. And while we're doing that, we have a chat. We try and make patients feel as comfortable as possible. They're often more nervous about the anaesthetic than they are about the operation. So we try and have a chat about something not to do with medicine, maybe their family or friends or something they've been doing, and try and make it a relaxed environment as they drift off to sleep. Then we give them some anaesthetic medicine, slowly drift away, and then once they're off to sleep, we safely manage them, take them into the operating theatre, and the surgeons do their work. I sit next to the patient just as we're sitting now for the whole operation, and once it's all finished, we wake them up. They go into the recovery room in the main theatre complex to wake up gently. We ensure that they're as comfortable as they can possibly be, using a mixture of painkillers and local anaesthetic that the surgeons have used. And once they're feeling well, they've had a drink, perhaps something to eat, they then either go back to the ward or back to our day unit. And then once they're ready, the relatives or friends can collect them and they can go home. Once we've done all that, at the end of the day, we have another meeting where we go over the day, we sort of feed back to each other about how we've been getting on. And then at the end of the day, once we've finished in theatres, if some of our patients are staying in overnight, if they've had a bigger operation or for medical reasons they need to stay the night, I'll go and visit them at the end of the day, check they're all right, check they're comfortable, and then I get to go home after that.
Just interested in that meeting you have at the end of the day. What's discussed there?
We might be using new techniques or new medications sometimes. We try and tailor the anaesthetic to the patient. And sometimes our patients may have a number of medical conditions that require, from our side, a bit more intervention. They may need extra pieces of equipment. They may need extra monitoring or more detailed monitoring to look after them safely. So sometimes we'll be feeding back that everything went well and everything was all right. We sometimes we're always thinking about, can we do better? What can we do to make the day go better? So maybe we've had a very long day and maybe the patients have overrun, the surgery may have been technically difficult, the anaesthetic may have been technically difficult. And it's how we've coped with that, how, if we were doing it again the following day, how might we improve things? Do we need extra staff? Do we need different equipment? So that we can feed back to our colleagues or managers about ways in which that we can be as efficient as possible whilst keeping the patients safe and looking after them as best we can. In addition to that, people may have ideas. We often have medical students who come and participate, so they may have questions about the day, and that gives them an opportunity to see that we also have questions. We don't know everything in our job about every single possibility, and I think it's good for the students, both nursing and medical students, to see us having conversations and saying, what did you think about this? How could we improve? But most of the time it's really to clarify that everything's gone well, everything's gone as planned, and that we're happy with the day.
And in a typical day, how many cases would you do?
So that can vary. If we're down in the day surgery unit doing generally the smaller procedures or shorter procedures, we sometimes have 6 or 7 patients over the course of the day. And that would mean maybe half the patients come in first thing in the morning, and then we'll have a second set of patients that come in the late morning. They can have a very early breakfast, sort of at 6 o'clock in the morning, and have their surgery in the afternoon, and that just helps them get better quicker afterwards if they have a more normal morning. Sometimes, though, we're doing reconstruction surgery, so we may be either using muscles within the body that the surgeons rotate as flaps to reconstruct breasts, or sometimes we use implants and other pieces of equipment. Sometimes those operations can take 5 or 6 hours, particularly if we're looking after both sides of the patient, and sometimes we have 2 surgeons as well. So we usually plan that in advance, and we often contact each other. As we see, I'm lucky that I work with my surgeons regularly, so we get together, and often if we're planning the surgery for the next few sessions that we're together, they'll tell me about patients who may have more complex surgery going on, or maybe more complex from an anaesthetic point of view. And we can plan that. So sometimes we have 2 patients on the list, one in the morning, one in the afternoon, but often we'll have, I would say more routinely, we may have 6 or 7 patients over the day. So each one would take perhaps approximately an hour to look after, sometimes a little bit longer.
And you typically work through that list until you get through that list for the day, or do you find that there are occasions when you have to sort of put a patient off to the next day, depending on how things go?
Sometimes that's inevitable, that we just don't have enough time in the day to look after all our patients. We take that side of things very seriously, and we all understand. I certainly have had friends and family who've had breast cancer and have come for treatment, and how important it is that we prioritise those patients and get them done. And I think the whole hospital takes that very seriously. Sometimes we have patients who are perhaps coming for follow-up surgery after their initial cancer's been removed, for example, for reconstruction or for other procedures that don't involve cancer. And sometimes those patients do have to be postponed to a later date on occasion, like you say, because we run out of time, or sometimes the hospital's very full and we just don't physically have enough beds to look after our patients. But I know that everybody takes, certainly all the patients that we look after, it is our priority to get them through, and we realise the stress and undertaking it can be to come to hospital and have an operation. So it does happen occasionally, but certainly our patients who have cancer, we want to expedite their treatment and get them done, so we make an enormous effort to make sure that they don't get postponed on the day.
I think that brings us on nicely to the next question, which is really what you see as being the biggest challenges in your role.
So I think there are a number of challenges. I wouldn't do the job if there weren't challenges to stretch you and get you thinking and improving, the job that you do. I think, as you say, trying to get all our patients done every single week is a big challenge sometimes. There are so many factors involved in getting a patient into theatre and having their operation, safely getting them awake and better and home. And any one of those steps can go wrong. It may be that there aren't enough beds in the hospital. We're very stretched for nursing staff if there's a lot of operating theatres running on that day, and there may be sickness or other reasons that we don't have enough staff. So the nursing staff can be stretched sometimes. And the same with the doctors as well. It may be that there are, people have got to be in more than one place at one time, and certainly in the surgeons and the anaesthetists, you can only look after one patient at a time. So the organisation does very well to manage us, and certainly in our anaesthetic department, they work very hard to ensure there's always somebody available to look after people on a daily basis. So that can be a real challenge for the surgeons.
So what's most rewarding about your job?
I think most doctors maybe would say that their patients are the most rewarding bit. It's looking after such a wide range of patients. I see ladies and gentlemen coming in to have breast cancer surgery of all different ages. As we know, so many people are affected by breast cancer. Most people know somebody who's had breast cancer in the family or friends. And those people, they're very nervous, they're often frightened about what's happening, what their future holds. And I do find it rewarding that we have patients who come in, they're so nervous when they first come in. We try and make them as relaxed as we can. I think showing them that we have a regular team that work together very closely, we all know each other well, we work together well, we get on well. I think that's evident when they come to theatre and they see us in the hospital setting. I think that helps to reassure patients, helps them to be a bit slightly calmer, think about the day as being a positive step, that they're having their surgery, the operation's being done, and at the end of the day, that's finished, that step's done and they're through, and we're going to help them through that day. And I find that hugely rewarding, and seeing the patients after their operations, they're awake, they're ready to go home, they're pleased that they're going home to their own bed at home with, you know, their own cup of tea and their own mug, and they're not staying in hospital if they can help it. But even if they are staying in hospital, having gone through that enormous step on the day, and seeing them with a smile on the face at the end of the day that it's finished, their relatives are coming in to visit them, and you know, our patients generally extremely grateful for the work that we've done, which is just part of our job, but it's lovely to be told that they're pleased with what we've done, they thank us, and sometimes we get patients coming back more than once for reconstructive surgery or other things, and I find it very rewarding when you see them on the ward and they say, "Oh, I'm so pleased it's you," or "Oh, it's you again, hello, I remember you from last time." That's really nice, and building up that doctor-patient relationship, which some people think doesn't really happen in anaesthetics. We're sometimes the mystery people, mystery doctors in the hospital, and I really like that I do have some regular patients that we see several times for perhaps ongoing reconstructive surgery, and I really like that continuity of care and find that very rewarding. It's much harder to measure sort of patient-related outcome measures in anaesthetics compared to surgery. However, we all like to look at the markers of how we're getting on. Are we doing well? Are we doing the best for our patients? Certainly on a general day-to-day basis, if I've got a patient who's comfortable after their surgery, they're not feeling sick, they're sitting up in bed having a cup of tea, they're feeling pretty much back to normal, I think that's a really good marker of us doing a good job. Particularly with our more complex patients, we're always looking for new things or different ways of managing patients to ensure that they feel great and they have the shortest stay in hospital as possible. It's better for the patient and it's better for the hospital. We can get more patients in if our patients go home and they're happy and settled and well at home. For example, we're starting to use regional anaesthetic techniques, so using ultrasound machines to target the muscle layers underneath the breast area and injecting local anaesthetic directly in between the muscle layers. So I'm starting to develop a service here where we use an ultrasound technique to do that. It then means we can really target where the local anaesthetic is and hopefully provide a nice long duration of anaesthetic block on the side of the surgery to get our patients very comfortable. That then means that they use less morphine and other drugs that may make them feel sick or make them feel perhaps a little bit confused sometimes after having it, which we need to do because they need to be comfortable. So we're bringing in new techniques like that. So, you know, using new equipment and things is really important, us having that availability so that we can provide different services, particularly for the patients having bigger operations. So I enjoy that side of it particularly.
Thinking about that new ultrasound machine, you know, what would be the process that you'd have to go through to bring it into the hospital?
So what we've done already is we've tried some new equipment in the operating theatre with technical people come in and set up the settings, very detailed settings for us so we get the best pictures, because sometimes the images can be difficult to see, pinpointing the exact location where we want to put the local anaesthetic. And we're working as a team within anaesthetics. There's several of my colleagues who are very experienced at regional techniques. So we're working as a team to develop our skills using the ultrasound machine to make it a technique that doesn't take too long to do, so we don't make our operations run longer, but at the same time there are huge benefits to having this equipment in terms of us being able to get the patients home quicker. As a result of that, we have more beds. A shorter length of stay means the hospital benefits from getting more patients in, which makes us more profitable as a business within the hospital, as we need to make money to pay for all the things that we do for patients. So we're hoping that if we develop this service, we'd be able to put a business case forward to pay for one of the ultrasound machines for our breast cancer service. As myself and another colleague who probably do over 50% of the breast cancer surgery in the hospital. And what we'd like to do is develop that by taking that to our departmental managers and show the benefits of what we're doing, both in terms of research that's out there in the literature about the benefits of regional anaesthetics for patients with cancer, in a number of different cancers. Actually, it's beneficial. And we hope that by putting together a business case of the benefits for the patient and the benefits for the hospital as well, that we would be able to facilitate money to pay for a machine, so that we'd be able to use that for our patients on a regular basis and give them the best possible care and facilitate their path through the hospital.
So if you could wave your magic wand to make things better, what would you do?
If I had a really big magic wand, I suppose I'd be out of a job, because that would mean we had a cure for breast cancer and we wouldn't see patients having surgery to facilitate their care. But I think you have to use a magic wand every day. It's looking after your patient as best you can, both in terms of your technical skills and your ability as a doctor, as a nurse, whatever healthcare professional you are. But it's also those communication skills as well. I hope that I bring that element of communication in terms of making patients feel welcome, that they feel safe, that they feel the hospital is somewhere where, although they need to be here, they actually want to come and have their treatment. They don't feel too frightened, we hope. We know that everybody feels frightened, and I feel they're so brave facing breast cancer head on and coming for their treatment and all the things that they need to have done. But I hope that I provide one of the jigsaw pieces to make up a big picture of them facing their treatment and going through the process with us in the hospital, and that hopefully I do the best I can for them.